I'm James Hackney, Assistant Professor of Physical Therapy at Missouri State University. In this video, we'll be demonstrating some of the material from our continuing education course, Getting Back in Stride, Rehabilitation for Runners. Right now, we are going to discuss a particular movement pattern variation which you may see in some of your running clients, valgus inclination of the knee during stance. I can't emphasize enough, if an individual is symptom-free, even if we perceive his or her structural alignment or movement patterns to be less than optimal, then we should probably not attempt to alter anything. Likewise, if they have symptoms, but the variations that we see don't explain the symptoms, then we should consider very carefully whether any change in that movement pattern is really justified. Generally, people's movement patterns are well adapted to their own structural variations, and most structural variations are only very weakly correlated to any future pain or dysfunction associated with running. Frequently, when we change a person's habitual movement patterns, there are consequences, and therefore we want to change them only if we can explain the patient's problem through the variation which we see. Here we see a frame from a video analysis of Melinda, who will be helping us with this demonstration. This image was generated with the Sports Motion System, which is a fairly inexpensive two-dimensional kinematic analysis system. As you see from this slide, Melinda has valgus inclination of 12 degrees of the right knee during mid-stance. If she were a running patient with right anterior knee pain, this movement pattern would provide an explanation for the symptom due to the effect that this movement pattern has on the Q angle. Although knee valgus is thought of as a frontal plane feature, in reality it is affected by both frontal and transverse skeletal alignment and habitual movement patterns. The first image demonstrates the relationship between the frontal plane variable, Q angle, and the transverse plane rotation of the femur and tibia. The second image can help you visualize the consequences on the patellofemoral joint of the forces associated with high Q angle. You can see that the lateral patellofemoral space is decreased, associated with higher compressive forces on the lateral joint area, which may lead to unusual articular wear, and also higher medial tensile forces, possibly associated with chronic sprain of the medial retinaculum or the medial patellofemoral ligament. So, if we meet a patient with anterior knee pain and this kind of movement pattern, what should we do about it? If you see the sign of knee valgus angulation during running, you should take some structural measurements, including Q angle, femoral torsion angle, structural varus or valgus of the rear foot and the forefoot, and tibial torsion through the thigh-foot axis. If these measurements indicate a structural explanation for the valgus angulation of the knee, then you likely may not be able to eliminate it from your patient's running kinematics, although you should seek to decrease the degree enough to allow your patient to run without symptoms. While strength of the lower body muscles is necessary for best possible running alignment, it is not enough to ensure it. Managing the forces applied to the knee during stance while maintaining alignment requires coordination of muscular forces across several joints, proximal to the knee, of the knee muscles themselves, and from the link to the ground. As your patient performs this exercise, be sure that the thigh is moving in the same plane as the shin. This movement might not be in the sagittal plane, but may be rotated externally if the femur itself is rotated externally. Also, the knee may not be going down over the second and third toes, as you frequently hear advised for this type of exercise if your patient has external tibial torsion. Start your patient performing the exercise at a slow speed, concentrating on alignment of the knee and maintaining the subtalar joint in a neutral frontal plane position. The knee joint angle of the squat need not exceed 30 degrees, since the knee flexion in stance phase of running does not exceed that joint angle. Start the exercise with your client in running shoes to provide some external support in maintaining the frontal plane alignment of the subtalar joints. Watch your patient to be sure that the heels are coplanar with the knees. Once your patient has mastered this, you can have her do it barefooted to increase the neuromuscular demand of distal stabilization, and further increase that demand by having her do it on an unstable surface like a foam block. Once she has mastered the slow speed exercise while maintaining correct frontal plane knee alignment, increase it to high speed by performing a drop landing. And then land and bound. You will want to take video as your patient performs this exercise because you will need to slow down the action in order to assess whether she is maintaining proper alignment. If you break down running into phases, it is a series of unilateral landing and bounding. Therefore, your next progression is going through the same series unilaterally, again attending to the previously described alignment of the knees and subtalar joints. Again, for the fast speed movements, you will want to take video so that you can check the alignment. It will probably take most patients a few weeks to progress through the series while maintaining optimal frontal plane knee alignment. During and after the patient has mastered this exercise series, it will be worthwhile to take running video analysis to check the patient's progress in improving frontal plane knee kinematics during running.